An ultra-short acting, highly titrable opioid that has redefined precision in modern anesthesia. I invite Dr. Jaydeep Ravi, Senior Consultant in Neuroanesthesia, Lizzie Hospital, Ernakulam, with decades of experience handling complex cases to guide us through this challenging topic.
Welcome, Dr. Jaydeep. As Jaydeep mentioned to me, it was very difficult to understand the title in the first place. I had to go to a dictionary to find the meaning of ephemeral. Over to you, Jaydeep.
Good morning, everybody. So I would like to thank the organizing team for inviting me to speak to all of you today. In fact, I was quite pleased when I was asked to speak about remifentanil. Primarily because remifentanil has been part of my clinical practice for nearly 20 years now. I've been working abroad for a majority of the time and was quite fortunate to have remifentanil available to me for use. And like millions of anesthetists worldwide, it quickly became a favorite with me as well. But like Manjit said, when I saw the official title of the talk, I was a bit perplexed. I thought I had a pretty good vocabulary, but I didn't know what these words meant. So, ephemeral and evanescent. I'd actually come across these words, but only with reference to some rock bands in the late 90s and the early 2000s. But I didn't bother to look up the meanings of these words. So if any of you in the audience are in the same boat as I was on that day, I've done the homework. So, evanescent means soon passing out of sight, memory, or existence, quickly fading or disappearing. And ephemeral means lasting or used only for a short period of time. In fact, I think these two words are perfect adjectives to describe remifentanil. So, remifentanil is not a new drug. It has been around for more than 30 years. But it's taken an incredibly long time for it to reach India. So initially it was developed in the 1990s, the early 90s, and it got an FDA approval in 1996 and was subsequently used in the US in July of that year. It was developed by the pharmaceutical company Glaxo Wellcome, and initially the drug was deemed a financial failure because of two of its properties, which is the analgesic on-off switch, which resulted in immediate pain when the infusion was interrupted, and the propensity to cause hyperalgesia. However, when it was released worldwide, over the subsequent decade or so, it quickly gained popularity and it became immensely popular in all the countries where it was available. So we know remifentanil is a selective mu-opioid agonist. It has a potency which is said to be twice that of fentanyl, 15 to 20 times that of alfentanil, and about 100 to 200 times that of morphine. It belongs to the phenylpiperidine derivative family, but it's structurally unique compared to the other phenylpiperidine derivatives because it has got an ester group, which makes it liable for action by non-specific plasma and tissue esterases and leads to its quick metabolism. So as you can see in the picture here, the picture on the left shows the structure of remifentanil, and you can compare that with the structure of the other phenylpiperidine derivatives. The area shaded in blue shows you the ester group. So remifentanil is available as 1, 2, and 5 milligram vials as a lyophilized powder. The formulation also contains glycine. It has to be reconstituted and then used, and it's usually diluted down to concentrations ranging from 25 to 50 microgram per ml before use. So once administered, it's got a rapid onset of effect. It's got a peak effect at about 1 to 3 minutes, usually about 90 seconds, and it produces profound analgesia. It's very lipid soluble. It has got a small volume of distribution, roughly around 30 liters, and it's got a rapid clearance. And that leads to a rapid offset of its action, and hence it needs to be given by an IV infusion. As I said before, it is metabolized mainly by non-specific plasma and tissue esterases, hence it can be given in patients with pseudocholinesterase deficiency as well. So this is a chart comparing remifentanil with other phenylpiperidine derivatives and morphine. What I'd like to highlight here is that remifentanil has got a relatively short onset time of 60 to 90 seconds. A peak effect comes by about 90 seconds, and it's relatively context insensitive. I'll be coming to that in the subsequent slides. So The metabolism is mainly by the non-specific plasma and tissue esterases, and the metabolism results in the formation of a carboxylic acid metabolite or remifentanil acid. The metabolite undergoes renal excretion and it can accumulate in patients with reduced renal function. However, the metabolite is metabolically inactive and its activity is said to be about 4,000 times less than that of remifentanil itself. So it can be safely used in patients with renal dysfunction. So the unique pathway of metabolism mainly leads to all the unique features of remifentanil, namely its brief action, its precise and rapidly titratable effect due to its rapid onset and offset, lack of accumulation, particularly in patients with renal and hepatic dysfunction, and rapid recovery after discontinuation of its administration. So coming to context-sensitive half-life, the context-sensitive half-life is the time required for the blood or plasma concentrations of a drug to decrease by 50% after the discontinuation of a steady-state infusion of the drug. So here the context is the duration of the infusion which maintained the steady-state concentration in the central compartment. Just to illustrate this, if you compare the context-sensitive half-life of remifentanil, alfentanil, and fentanyl, you can see that with remifentanil, irrespective of the duration of the drug, the context-sensitive half-life does not change much. Whereas with alfentanil, you'll see that there's a steady rise in the context-sensitive half-life for the first couple of hours or so until it reaches the ceiling, and then it plateaus out. Whereas with fentanyl, as you can see, the graph just goes off the charts. So remifentanil has got systemic side effects as well, some of which I would like to highlight is the propensity to cause hypotension. So you need to have your vasopressors on hand when administering it. It can cause bradycardia, rarely progressing to a cardiac standstill, but that is usually with higher doses as well as bolus doses. So that can largely be negated by using pre-medicants like glycopyrrolate. It's a potent respiratory depressant and can cause apnea. It can also cause muscle rigidity, especially when used in larger bolus doses, and it can also cause hyperalgesia, especially when used for a longer period of time as an infusion or by using a larger dose of the drug. So coming to the dosage, the recommended dose during the induction of anesthesia is about 1 microgram per kg per minute over a minute, and the induction dose can be reduced, especially in the elderly, particularly in patients above 65 years of age, by about 50%. After a minute, you can come down to a maintenance dose of 0.05 to 0.5 microgram per kg per minute, and of course this can be titrated to effect. If you're using a target-controlled infusion, you'd aim for effect site concentration of anywhere between 3 to 10 nanogram per ml. This would depend on the type of patient and also upon the type of surgery and the particular surgical stimulus that's taking place at that time. If you're using it as part of TIVA, if you're having a patient who is spontaneously breathing, you can go for a higher propofol and lower Remi strategy with a propofol effect site concentration of between 4 to 6 and Remi between 1 to 3. And if you have a patient on controlled ventilation, you can go for a lower propofol and a higher Remi strategy with a propofol effect site of about 2 to 4 and remifentanil at about 6 to 12. Again, you can titrate this according to the patient's response. Now, to calculate the remifentanil infusion, I have a simple formula, especially when you're doing a manual infusion. So you dilute the remifentanil down to 50 micrograms per ml, and then you multiply the weight of the patient by 0.12 to give the rate in ml per hour, and this equates to 0.1 microgram per kg per minute. So for example, if you have a 70 kg patient, you would multiply that by 0.12, which gives you 8.4 ml per hour, and this translates to 0.1 microgram per kg per minute. You might still need a calculator though. Coming to uses, Remifentanil can be used in a variety of situations, in a variety of surgical procedures on a variety of patients. But what I'd like to do is highlight a few areas where it is particularly useful. So I'll start off with neurosurgery first. I do mainly neuroanesthesia. So the advantages of remifentanil for neurosurgery include a dose-dependent suppression of EEG. It does not increase the ICP. It does not impair the cerebrovascular carbon dioxide reactivity. It also provides good hemodynamic protection, particularly not only just during intubation, but also when the surgical stress is high, especially when fixation of the head on pins. It's also useful for using relaxant-free anesthesia, especially when you're using neuromonitoring. And most importantly, it produces an early and predictable post-op neurological assessment. So coming to craniofacial surgery, it can be used for a variety of surgeries, including oral maxillofacial surgery, like maxillary and mandibular osteotomies and facial fracture repairs. It can also be used in extensive craniofacial tumor surgeries, where it can produce controlled hypotension, thereby reducing the intraoperative blood loss and allowing for a controlled emergence leading to a safe extubation. In ENT also, it's quite useful, especially in FES, where the blood pressure control leads to better operative conditions. The surgeons will complain less. Also, during extubation on emergence, there is less bucking and coughing, leading to less bleeding. And also, the patients are able to obey commands earlier, leading to a better recovery. It can also be used in resection of airway tumors, where you can have a smoother extubation and an improved safety of extubation. It's also useful in procedures like microlaryngoscopies, which can be stimulating, but it's a short procedure and there's no significant post-op pain, so remifentanil can be ideal in such cases. In cardiothoracic surgery also, it has been used extensively. The beneficial effects are said to be, it provides good hemodynamic control during periods of intense surgical stimulation. It reduces hypnotic drug requirements and attenuates the neurohumeral stress response. It can be used in minimally invasive CABG as well, where it can lead to shorter waking times and early extubation of patients. It has been used in carotid artery surgeries as well, especially in patients undergoing the procedure under general anesthesia. It leads to rapid recovery with an earlier eye opening and earlier extubation. It allows an earlier neurological examination as well. In obstetrics, it has been covered by my colleague, Dr. Suvarna. I'll just brush through it. It's been used in labor analgesia to high maternal satisfaction when compared with fentanyl PCAs. It readily crosses the placenta, but it undergoes rapid fetal elimination, so it does not affect the fetus much. The typical bolus dose would be about 20 micrograms with a 3-minute lockout. Some places use about 30 to 40 microgram boluses as well. It has also been used in general anesthesia in obstetric patients when they come for cesarean section, and it's very effective at obtunding the airway response, the response to airway manipulation and to surgery. But the neonatal effects in this case can be more pronounced, and so the neonates may need assisted ventilation. Another area of interest is when you need to intubate patients without using muscle relaxants. You would come across these kind of patients in patients with neuromuscular disorders like myasthenia gravis and myotonia. When you're using neuromonitoring like for thyroid or parotid surgery or in neurosurgeries, or when you have short procedures where you require intubation but you don't necessarily require muscle paralysis. So, for example, ENT procedures. So in these cases, you would use the dose, remifentanil in a dose of about 1 to 3 microgram per kg over 30 to 60 seconds, which is administered 90 seconds before the intubation. The apnea time with remifentanil of 1.5 microgram per kg is similar to that you get with succinylcholine. The ED95 for acceptable intubating conditions is said to be about 2.4 microgram per kg. Bear in mind that such large doses can give rise to an increased risk of hypotension, bradycardia, and chest wall rigidity, especially with the higher doses. In ICU also, it has been used as an analgesic-based sedation alone or in combination with other hypnotic agents. The patients are usually said to be more comfortable, cooperative, and they have a better awareness of surroundings. There is reduction in the time of mechanical ventilation, leading to a smoother extubation. It can also be used in patients with renal and hepatic impairment, which is common in these patient subsets. And it's said to be overall cost effective because there is reduced use of other sedatives, there's reduced time on mechanical ventilation, and a reduced ICU stay for these patients. So in conclusion, this remifentanil is a very useful drug in the anesthetist armamentarium. It can be used in a variety of situations. It can be used in the OT, in remote location anesthesia. It can be used in the ICU. It's useful in anesthesia for almost all the specialties. The drawbacks could potentially be the cost. It costs about 1,000 rupees for a 1 milligram vial. And also, it would take some getting used to. So once people are familiar with its usage, I'm sure it will be very, very popular in India as well. Thank you.